Welcome everyone for coming to Saturday's lecture series presentation. This is our second one for the year. My name is Aaron and I'll be your presenter for today. I am a PT here. I split my time between the orthopedic clinic here and also the neuro clinic across the street. So today's topic, we'll be talking about dizziness. It's a common condition, especially as we get older, and it can be pretty debilitating if you've had it or if you know someone who's had it. We'll talk about three different common conditions that can cause dizziness. So let's get started. So if you've ever had dizziness or you know someone who's had it and been to the doctor, your doctor might tell you, oh, you have vertigo. Just go see a neurologist or see a physical therapist. It's rather a misnomer, the term vertigo, because it's really not a disease itself. It's just a symptom, just like pain. It's a symptom of an underlying neurologic condition. So vertigo is really a sensation where you feel like you're spinning or moving in circle, whereas in fact you're not, and you're stationary. And like I said, it's a clinical symptom of an underlying vestibular condition. And by vestibular, we're talking about structures inside your inner ears. The vestibular system, you got one on each side of your brain, and their primary role is for your balance and your equilibrium. We'll talk about three very common diseases that can cause vertigo or dizziness. For the purpose of today's presentation, we'll use vertigo and dizziness somewhat interchangeably. So the first condition we'll talk about is called benign paroxysmal positional vertigo. It's a mouthful. Second one we'll talk about is called vestibular migraine. And the third one is vestibular neuritis. It's a little grainy. Let's see. It's a little better. Okay, so before we dive into the conditions, let's do a little overview on the anatomy of your ear. So your ear can be broken down into three parts. You got the visible earlobe, which is the outer ear. Its function is to catch the sound that you're hearing, such as I'm speaking right now. And then you got the middle ear, which is at the border of your skull. It contains your eardrum and a few small bones that can conduct and transmit the sound waves to the structures deeper inside. For our topic today, we're concerned about the inner ear. So that is where the vestibular system and the vestibular organs live. They have specialized sensors that can detect any type of movement of your head, your body, sensation of acceleration and deceleration. And its main function, like I said, is to help you stay steady. So the vestibular system, let's take a close-up look here. So that is the inner ear. It's just a zoomed-up image. Looks like a snail. The shell of that snail is called the cochlea. That's for hearing. And the blue circular things, those are the vestibular organs that we are going to look at and examine today. And collectively, they send information to your brain on things like your hearing and your equilibrium. So they work hand in hand. All right, so let's start with our first condition, which is called the BPPV, or Benign Paroxysmal Positional Vertigo. I'll start with a patient case for each of the condition. So we have our patient, Miss Jane here. She is a lovely 62-year-old female. She came to the clinic this morning and told me that she had a very sudden and violent onset of room spinning sensation. That occurred this morning when she got out of the bed and rolled over to reach for her phone. The episodes were pretty brief. It only lasted about 30 seconds. However, it happened a few more times later that morning when she was getting dressed, when she was trying to wash her hair, and also when she was putting on her shoes. She also felt nauseous with some of those episodes, but she feels fine when she doesn't move her head or doesn't change her position too quickly. And as a result of those episodes, she's feeling a little unsteady right now coming to the clinic. So the main things that, well, actually, before we start, anybody has had this condition before? Or
I've had vertigo, but I don't know if it's the position.
okay. Yeah, so the key things about this type of condition is that it occurs, the vertigo occurs when you change position of your head. All right, so such as when she was rolling in bed, when she was sitting up, or when she was lying back, or tipping her head even. It doesn't happen when you're just sitting here and being completely still. All right, so it's different types of causes for vertigo. So if you come here and tell me, I feel dizzy right now, chances are you don't have this condition. And the other characteristic for the BPPV is that they don't really experience anything other than the vertigo, well, besides the nausea. There's no hearing loss, there's no ringing in the ear, and they don't report any fullness in the ear. And the episodes are also very characteristic on their own. They are very brief, but very intense. It's not constant. It only happens when you're moving your head, and when you sit still for a little bit, it settles down and you feel fine. So BPPV, if you've had it or if someone else in your family has had it, if you go to your physician, your PCP, or a neurologist, they might say, oh, you have some issues with the crystals in your ear. Anybody heard of that term? Some crystals in the ear? Yeah. So that's in fact true. This condition is due to a dysfunction of the tiny little crystals in your ear. Where are the crystals? So again, this is the zoomed up image of the inner ear structure. That's the snail shell, and these are the vestibular organs. The crystals are typically in the middle part of the vestibular system or your inner ear. They're made of calcium, and usually they don't move. They just kind of stick around on the wall of that middle structure, right? And that's it. Their function is to detect any movement of your head in daily life. However, when we get older, particularly for females, we tend to lose our bone mineral density, and our metabolism of calcium and vitamin D is not as good as when we were younger. So because the crystals are made of calcium, the integrity of those crystals degrade over time, just like the rest of our body. And that increases the risk of those crystals moving around and falling out of place from the middle structure. And when they start to free floating in the ear, so when they move out of this portion and get into those circular things, that's when you get the dizziness, when you change position. So I'll help you visualize it this way. One of those circular structures is exactly in the same orientation as your earlobe. So if you think about it, when you lie down on your back after, let's say, a night of sleep, the crystals are subject to gravity. So gravity can start pulling on any crystals that whose integrity has become impaired over time. And those crystals can become loose and they fall out of place down to the bottom of your earlobe or one of those canals. And when you sit up first thing in the morning, they start moving around. And that's how typically people describe this condition. It's that the first thing in the morning when they wake up, I feel very sick. Because the crystals are now moving around in the ear. Any questions on this? Yeah. So how common is this condition, and what are some of the risk factors? It's actually very common. Over the age of 70, about 1 in 10 people can have this in their lifetime. it accounts for 50% of all causes of vertigo. So it's the most common cause of dizziness and vertigo for people that seek medical attention. Worldwide, about 2.4% of the world population can develop this at some point in their life. And it's more common after the age of 50 and becomes increasingly more common as we get older because the integrity of those crystals become less and less. Like I said, females are more likely to get affected than males because another thought of it is something to do with the effect of menopause. It affects your estrogen and also and females tend to lose the bone mineral density faster than males. That's why I always tell people, whether or not they come here for vertigo, for this condition or not, take your vitamin D, take your calcium, particularly on the northeast region over winter times where we don't get a lot of sunlight. Vitamin D supplementation can definitely reduce the risk. So some common causes for this condition. First one is inactivity, so like sleeping, bed rest. Activities that include bed rest are sleeping overnight, going to the dentist appointment, or even getting a spa or getting a massage where you're on your face or on your back for a long period of time. First thing you sit up, if the crystals are moving, you get vertigo or this condition. Second common cause for this condition is trauma to your head. This is more common for the younger people that are affected. If you get whacked in your head very hard, the impact of the force can shake those crystals loose. Or a fall. Like if we get older, then you fall, you hit your head, you might break your hip and have this at the same time, which is unfortunate. So try not to fall. So risk factors, like I said, first one is age. As we get older, it's more common. Second one, any type of conditions that affect the integrity of your blood vessels or your circulations, such as hypertension or clots in any of the arteries. And the reason for that is the vestibular structure, even though it's a zoomed up image over there that we just saw, in reality, it's only the size of your pinky nail. So the blood supply to this structure is even more delicate. It's very, very tiny. If you have hypertension, then those blood vessels can be under chronic stress, and then that can disrupt the integrity of the crystals in the structures as well. All right. Any questions about causes and risk factors? We'll talk about some treatments. So when you do get this, what happens? What should you do? Well, unfortunately, there are no medications that work because it is a condition of the crystals. It's not something that can be managed with medications. However, your doctors might prescribe you with something. Typically, it's called meclizine, which is a motion sickness pill, or Zofran, which is for nausea. But like I said, those are only for symptoms. They don't treat the underlying cause for this condition. Surgery, yeah, it's an option, but it's only the last resort for people that do not get better with physical therapy for this condition. And it's very drastic. Essentially, there are two approaches to surgery. They can completely plug that circular structure that we just saw and just make it cemented so that nothing can move inside. Or they cut out your vestibular nerve completely. Yes, you don't get dizzy, but you lose your balance function on that side of your body completely. It's not coming back. So it's only reserved for people that do not get better and that have recurrent cases and they just cannot live with this at all. The gold standard is physical therapy. We call the treatment a repositioning maneuver. So essentially, we're using a series of head movement and gravity to kind of physically put the crystals back in place. So if they're out floating in the bottom of your ear, we're trying to roll and turn you in a specific sequence and put the crystals back where they belong. It's 90% effective. Any questions on treatment? No, pretty straightforward. All right. Shall we move on to the next condition? Yeah. All right. We'll talk about vestibular migraine next. Let's also start with a patient case. So Miss Sarah, she is a 34-year-old female. She comes to me and tells me that she has those episodes of swaying and rocking and spinning dizziness that have occurred, but the duration of those symptoms lasts anywhere from a couple minutes to sometimes 2 days. She had a history of migraine when she was a teenager, around the time where her periods started. Nowadays, when she gets those dizzy spells, sometimes she has a headache, but sometimes she doesn't. She notices that the most consistent triggers for her dizziness are scrolling on her computer and also the bright lights at her office. Sometimes with those episodes, she feels very sensitive to sound and she gets nauseated as well. So right off the bat, the presentation for vestibular migraine is quite different than what we just saw with BPPV. The things that stood out to me include she has a history of migraine, and in fact, people who's had migraines in their lifetime are at higher risk for developing vestibular migraine down the road. The episodes of those symptoms are also longer, from minutes to days now, rather than a couple seconds. And the triggers are also different. It's not with changing her head position, it's the environmental and external factors that are causing the issues now. Any questions about what this is, or just migraine in general? Yeah.
Do you experience like an aura with the migraine, or?
Yes or no? Yeah. Some people do, some people don't. Yeah. Just like regular migraines, they might get an aura, and it can come in any forms of symptoms. Sometimes it's weakness in the arm, sometimes it's numbness in the body, or sometimes it's feel like something is about to happen, or sometimes they just don't have an aura at all. It just happens when they're triggered. So vestibular migraine, now we're talking about a condition that has connection with your brain, so how your brain is processing the structure. When we talked about the BPPV, it's purely the inner ear. Now, your brain is involved in this condition as well. It's a neurologic condition, and the theory, or not the theory, the mechanism is that when you get those episodes of migraine, there is a temporary reduction of blood flow to the brain and your inner ear. It's almost like your blood vessels are spasming, and that's why sometimes people get headaches. This image here just shows there are a ton of pathways, how your nerves are connecting structures to your brain. So this tiny little structure is what we just saw, that's the inner ear. And it's got many, many different ways to enter and send signal to your brain. Anywhere along those pathways can be interrupted or disrupted as we get older or due to external factors. The other mechanism is that along those pathways, your tissues and your nerves become more sensitive to any type of inflammation. So people are more prone to developing those symptoms. And like I said, a couple of things that you should keep in mind when you are experiencing or thinking that you might have this condition are that you may or may not have a headache with this. Even though it's called a vestibular migraine, you don't have to have a headache to be diagnosed with vestibular migraine. The duration is longer. That can help you differentiate, is it a crystal issue or is this potentially a vestibular migraine issue? And the triggers are often external, such as lack of sleep, lack of hydration, certain food, stress at work, stress with friends or family. And also sensory stimuli, like lights or sound, which are common for people with migraines. Those are typical triggers. And it gets worse with physical activities. So when people do get those symptoms, they don't want to move. They just want to sit still and leave them be. Any questions about the mechanism of this condition? No? It's less common than the crystal problem, the BPPV we talked about. However, the onset is also a little bit younger. Now we're looking at the age bracket between 30 and 40-year-olds. Females are 5 times more likely than males to get diagnosed. Some risk factors include genetics. If you've had family members who have a history of migraines or this condition, then you can develop this too. Trauma to the head is a risk factor for pretty much all neurologic condition. Like I said, diet, spicy food, wine, cheese, processed meats, those are known triggers for people to develop migraines. Hormonal changes, which is why females tend to get this condition more frequently, and also environmental factors. Treatment. Treatment for vestibular migraine includes a couple different aspects. So when it's happening in the moment, we're talking about abortive treatment. We want to get rid of the symptoms in the moment if they're experiencing this condition. It's typically managed with medications. So this is where a neurologist should be involved. The purpose for abortive treatment is to get rid of your headache, if you have it, or the dizziness that you're experiencing. More importantly, preventative treatments are what can help people, what can keep people from developing this condition or keep the frequency at bay. Again, it can be managed with a variety of different medications. Like I said, because it's a condition that can cause by spasms of the blood vessels, any type of medications that make your blood vessels dilate, such as beta blocker or even seizure medications, have been shown to be effective. Believe it or not, Botox works too. Sometimes if the muscles are super tight in the neck and face, that's an external stress for your brain to interpret information in a wrong fashion. So Botox to the face can calm things down a little bit too. Lifestyle. So this might sound cliche, but keeping a healthy lifestyle, sleep, stress, exercise, and if you know any foods that can trigger your migraines, stay away from them. Usually they're processed stuff, which is inevitably common in our diet. Vestibular rehab is also a effective management strategy, but it's only for people that have developed this condition for a long time. If it's become a chronic issue, then what we typically see is it affects their vestibular function, such as their balance, their posture, and the tension of their muscles in the head and neck. So as PTs, we can help you address your balance and any of the things that you're struggling with. If you've just started to have this condition, our role might not be so imminent or prominent, I guess, because we don't really need to intervene if the symptoms just to go away on themselves. Any questions about this condition? Or anybody has had migraines in their life? Yeah. Does it sound similar to a regular migraine? Yeah. It's basically just a regular type of migraine with a vestibular condition where you get the dizziness and imbalance. So they merge together. If you've had a migraine in the past, let's say you developed the crystals issues at some point in your life, there's a possibility that the symptoms, the vertigo symptoms from the crystal issues can merge with your migraine from years ago, and you might develop into this. So they can kind of morph into a new condition, which is unfortunate. Yeah, your brain is very interesting. All right, last one. We'll talk about vestibular neuritis or vestibular hypofunction. It's quite a terminology. So basically neuritis means inflammation of the nerve, some kind of inflammation of the vestibular nerve. And when the nerve becomes inflamed, it causes what we call hypofunction, hypo meaning less. So the function of your vestibular system become less. Our unfortunate patient here, Mr. David, he is 48-year-old. He reports a very sudden and dramatic onset of severe spinning sensation that happened 24 hours ago. He woke up feeling extremely nauseous and dizzy and has vomited multiple times. So far, it sounds like the BPPV issue. There is some similarity there. However, he describes the dizziness as constant and unrelenting. Nothing he does makes it go away. And it's worsened by any movement of the head. Coincidentally, he also tells me that he just got over a flu, a very severe flu, last week. So I think the key findings that set this condition apart from the crystal issue are that he has a history of a flu, some kind of viral infections in the past, or recently rather. And also the symptoms, even though they are very similar to the crystal problem, the BPPV, it's constant. It doesn't go away. Nothing he does can make it go away. And it's worse with any type of head movement. So why is that? Well, what's happening? So again, we'll go back to the snail structure here. The top yellow thing, that's the nerve. That's the vestibular nerve. And it contains all the information from your vestibular system to your brain. The red little bulge, that's just showing an inflammation of that nerve. So under normal circumstances, we have, like I said, we have vestibular systems on both sides of your brain. There is a constant background noise. The systems are always firing and working at the same rate when you're not moving, such as like how you're doing now. So they're kind of just flickering and firing. When you turn your head to one side, the vestibular system on that side fires a bit more, and the system on the other side fires a little bit less. So the mismatch is what your brain can know, oh, I just turned my head to the left. With a vestibular neuritis, because there's inflammation of one of the nerves on either side, then that side becomes less functional. It's firing less. So now, even though you're not moving, there's this mismatch. And your brain thinks you're constantly turning your head, when in fact you're not. That's how you're getting this constant spinning sensation, and it doesn't go away. There's nothing you can do to make this match come back, at least in the first couple of days. Make sense? Yeah, it's pretty severe. And like I said, it's worse during the first 48 to 72 hours. And that's typical with any type of inflammation in your body. If you get whacked in the body, the bruise might start to develop within the first 3 days. That's just how your brain processes inflammation. And it gets worse with head movement, because especially if you turn your head to the side that's inflamed, because then you're stimulating the side that's already not working too well. So people typically want just lie flat and don't move at all, and keep their eyes closed, because that somewhat helps their spinning sensation. And this is the typical timeline for vestibular neuritis. First 3 days, awful. You just get through it. Then try to take some medications, take the motion sickness pill, take the Zofran. If you have nausea, let's just manage the symptoms. As the inflammation kind of goes down a little bit after the first 3 days, your symptoms become less. And your brain starts to recognize that, oh, you're not actually turning your head. There's something going on with the signals from your systems. So let's see if we can adjust and then tune up the signals a little bit. So over the next couple of days, in the first week, your brain starts to adjust for that mismatch. And after 2 weeks or 4 weeks, the inflammation will resolve eventually, and also your brain will learn to compensate, and that's how you start to feel normal again. So people typically don't feel normal after about a month. Yeah, so it can have a pretty long-lasting effect. However, for more severe cases where the nerve is completely inflamed and or the function is completely gone, that's it. There's no coming back from that. For that, we got to do vestibular rehab, and then we'll help you kind of retune the sensitivity and function on both sides of your head. So treatment, like I said, medications can help you manage the symptoms of the spinning sensation and the nausea. Corticosteroids, because steroids are good for inflammation, they are also effective for this condition. Your doctor typically will prescribe you a course of steroids for 10 days, and you take those steroid pills for 10 days just to calm the inflammation down. Vestibular rehab is extremely effective for vestibular neuritis. The lady here, what she's doing is what we call a vestibular exercise, where you're looking at a stationary target and you're turning your head side to side. So we're kind of stimulating your vestibular system in a slow and controlled fashion. In the process of doing that, your brain will start to adapt and recover from the inflammation and the impact it had. And also, if you have this issue and have any balance issues, then we can address that as well. Any questions about treatment for this? No? Pretty straightforward. All right, so this is a table that differentiates the common vestibular conditions. With BPPV, the duration is very short, all right, couple seconds. Very rarely does it go above 1 minute. And that's a more rare variant of BPPV. Vestibular migraine, the duration is longer, couple minutes, hours, even 2 days. Vestibular neuritis, it's constant for the first couple of days. So the duration alone can help you really differentiate, what you might have, what you might not. Triggers. BPPV, it has to be triggered by change in your head position. Whereas vestibular migraine, it's more external factor. Neuritis, well, too bad, it just happens on its own. The thought is that if you've had an upper respiratory infection or some kind of viral infection, even though the virus itself can be managed with medication, there's a possibility that they might migrate. The virus itself can move inside your body, and when they do land in your vestibular system, you get this. Almost 60% of people who have vestibular neuritis have had some kind of infections recently. Do you get headaches with BPPV? No. Vestibular migraine? Yes or no? You don't have to have it. Vestibular neuritis? No, there's no headache with this. And then lastly, it's a technical term called Nystagmus. Nystagmus is involuntary twitches of your eyes. So this person is not doing it on purpose at all. The eyes are just twitching. What's happening here is when there is some kind of insult to your vestibular system, it disrupts the flow of information and also the function. As a result of that, your eyes start to move involuntarily. The direction and the duration, also the intensity of the nystagmus is extremely helpful for us to diagnose what's going on and also to assess the efficacy of our treatment. So don't be surprised if we're like this close, face to face, looking at your eyes, because we're trying to see if we can capture any of the eye movements here. Just a Just from my personal experience, a lot of people, BPPV, because it's the most common condition for dizziness, a lot of the times when you go to your doctors and tell them that you have dizziness, they might diagnose with the BPPV. And it may be a misdiagnosis. So yeah, hopefully, just knowing the duration and the characteristics of different conditions can help you make an informed decision for yourself, and don't freak out too much. All right. Any questions for me at all on any?
Is it nystagmus with neuritis?
Yes. Yeah, with the neuritis, the nystagmus is constant. When there is a mismatch of that firing rate, it's going to keep going until that inflammation starts to resolve a little bit, and then the nystagmus will settle down. And people can feel the nystagmus too. They can feel like, I cannot stabilize, I cannot look at something accurately, and my eyes are kind of just jumping around.
Do people drive with some of these conditions, or no?
Neuritis, no. Also, if you have the acute onset of neuritis, you don't want to drive anyway because you're miserable for the first couple of days. BPPV, yes, because if you kind of just sit still a little bit and then don't turn your head too quickly, you're fine. And also, the interesting part about the BPPV is that you don't really trigger the symptoms if you turn your head side to side, if you're upright per se. It's more so when you change your head position front and back, or when you're on a flat surface. So driving typically is okay for BPPV. That's how people come to our clinics and get treated for BPPV, because they can still drive. With the migraine, you got to be careful because the lights, the sound, the passing traffic, they're all known triggers for the migraine. So if you happen to have the episode while you're driving, then that's dangerous. Any other?
Is the Dix-Hillpike maneuver for the BPPV?
Dix-Hillpike?
Is that what it's called?
Yeah, so the BPPV is diagnosed. Again, the gold standard is also with physical technique to help you diagnose. Imaging won't show. There's no imaging that can tell you where the crystals are. Well, there is one, but it's not imaging. Take a guess. It's autopsy. Yeah, so let's hope we don't get there to diagnose the conditions. Yeah, so it's, in the clinic, we do different maneuvers to help you not only diagnose, but also to treat. So that's why I really like about this condition, because it's non-invasive. We can manage it without any type of side effects or radiation to your body. And we don't need medications for the condition to go away.
And how is that maneuver different from the other ones that you have on?
So Megan was talking about a testing technique that we use to diagnose BPPV. It's called the Dix-Hillpike maneuver. And the one I have here, it's a little small to read, but it's called the Epley maneuver. That's for treatment. So it's a little frustrating, just like medicine in general. A lot of European doctors like to name things after themselves. So when we talk about these things in the clinic or to your patients or in the literature, it's just a lot of different names. Dix-Hillpike, that's the last name of two. Those are the last names of two physicians. Epley is also a physician, and there are other like. The Gufani is also another physician who is still alive and doing research. So, that's just different techniques, different maneuvers, and there are always new ones that are being developed over the years. The efficacy for each is somewhat comparable, but there are many different factors we consider when choosing which one to use.
How successful are those maneuvers?
For the most common type, if the crystals are in the canal that's in the orientation of your earlobe, that's 90%. Sometimes some papers report even 100%. So it's very successful. For if it's elsewhere in the ear, it's a little bit less, just because of the orientation of the ears. And also, as we get older, everybody is a little different in their anatomy. Some people's ears, the structures are more like a C shape. Some people are more like a U shape, so the angles might be a little sharper. That can all affect the efficacy of those maneuvers. And we might have to try those techniques multiple times to see if it works or not. And again, we can't know unless we do an autopsy. Yeah.
What is the Gufani maneuver?
The Gufani maneuver, that's so that's for the crystals if they're stuck in this canal, like this circular structure, whereas the Epley is for the one on the back. Yeah, so just different maneuvers for different locations of the crystals. Because the orientation is all different relative to gravity, so there's lots of them.
For these maneuvers, about how long does it take? Do they come for a month to do this, or weeks, or what is the progression?
Yeah,
of getting better with this.
This is also why I like about this condition, because it's not like the traditional physical therapy where you come in twice a week, let's do it for 8 weeks. If you're lucky, we'll get you out on the first day, right? Because it's 90% effective, and we can manage it pretty much on the spot. That said, for some people, it might take a little bit longer. We might need to repeat the maneuvers a couple more times. So we might have to do it 2 or 3 times. That might take a little bit longer. But typically, for the most effective cases, 20 minutes. From when you walk in doing eval to when you walk out, 20 minutes, that's plenty. Because your history is very, we can diagnose this condition based on what you tell us about your symptoms. And then we can go straight into the assessment and the treatment. The maneuver itself only takes 2-3 minutes to perform. So yeah, if you're lucky, we can get you out in under 30 minutes, and you won't have this for at least a couple months or even a couple years. However, if you need a few more repeats of the same maneuver, then we might do it. We might do all of them on the same day, or we might need to have you follow up the next day or in a week, because for some people, it's the severity of their symptoms can be debilitating, and they cannot tolerate more than just one maneuver. So they might have to say, "That's it. I've had it for today. I got to come back next time." And typically, people hate us when we do this because you're experiencing those symptoms, but they feel much better afterwards.
Thank you.
Yeah.
When we get the goggles, is that used more for diagnosis, treatment? What do you use the goggles for?
Yeah, so we also have a pair of goggles. Well, we call them vestibular goggles. Essentially, they are infrared goggles, and they have video cameras inside that can capture the eye movements, such as the ones we just saw. They can magnify the movements of your eyes, and they can record. So we don't have to take you through the maneuver multiple times to see which way your eyes are moving. I typically use those goggles both for treatment and also for diagnosis. They just tell us, if there are still residual crystals moving around. Yeah. Any other questions, Megan?
Have you had any vomiters?
Many times. It's very common to feel nauseous with the BPPV, because essentially you're spinning in a circle. Your brain thinks you're spinning in a circle, but you're not. So the mismatch between reality and what your brain thinks is very significant. People will feel sick and people will feel nauseous. So we tell people, try not to eat before you come in. Yeah. Any other questions? Anything else? No. Pretty good? All right. Thank you for your time.